So we have with us Dr. Gregory Brent. He's an endocrinologist and the interim chief of endocrinology and diabetes and professor in the Department of Physiology at David Geffen School of Medicine at the University of California in Los Angeles. He's also an endocrinologist at the Veterans Affairs Greater Los Angeles Healthcare System. Dr. Brent received his medical degree from the Keck School of Medicine at the University of Southern California and has been in practice for more than 20 years. His research focuses on gene regulation by nuclear acting hormones, especially thyroid hormones and retinoic acid, and he has authored numerous publications. Dr. LoPresti, Jonathan LoPresti, is an endocrinologist at the Keck School of Medicine at the University of Southern California in Los Angeles. Dr. LoPresti received both his medical degree and his PhD in physiology from the University of Southern California. He completed his residency at the LAC and USC medical centers. Dr. LoPresti has contributed to over 50 presentations, recently lecturing on a case of an aggressive papillary thyroid cancer arising in the third trimester of a pregnancy. In addition, he has had leadership roles in the American Thyroid Association and has been published in numerous journals, abstracts, and book chapters. And lastly, we have Dr. Jerome Hershman, who's an endocrinologist and a distinguished professor of medicine emeritus at the David Geffen School of Medicine at UCLA, and the director of the endocrine clinic at the West Los Angeles VA Medical Center. He edits the online journal Clinical Thyroidology. Dr. Hershman received a BS in chemistry from Northwestern University in Chicago, an MS in chemistry from California Institute of Technology, an MD from the University of Illinois School of Medicine in Chicago. He was a resident in internal medicine at Beth Israel Hospital in Boston and the Boston VA Hospital, and trained in endocrinology at Tufts New England Medical Center. Dr. Hershman spent 3 years as a faculty member in the Department of Medicine at Northwestern University and 5 years at the University of Alabama in Birmingham before moving to UCLA in 1972. Dr. Hershman's current research focuses on the pathogenesis and management of thyroid cancer. Welcome to all.
All right, well, thank you so much, Roberta. It's really a pleasure for all of us to be here with you. I think this is my fourth ThyCa meeting over about the last 20 years. The way that we'll do the presentation today is that each of us will spend about 10 minutes going through some material that we've prepared. And then we want to leave at least half the session for questions and interaction. I've given this topic the last several meetings and always learn a lot from those who ask questions, and we look forward to that today. One commonality for almost all thyroid cancer patients, certainly those that have had thyroidectomies, is that they're on thyroid hormone. And thyroid hormone replacement in hypothyroidism is just to make the thyroid normal, but in thyroid cancer, of course, it's not only to make the person euthyroid, as we say, but also as part of the treatment. So there's treatment targets of TSH because TSH does promote cancer growth. And Dr. Hershman will talk about those towards the end. So I'll give a little introduction to thyroid hormone replacement and thyroid test monitoring. Dr. LoPresti will then talk about thyroid hormone metabolism. And often we start with this, but I think if I talk a little bit about the terminology as you're using preparations and thyroid hormone replacement, then you'll understand the metabolism a little bit better. And then Dr. Hershman's going to talk about some challenges taking thyroxine, effects on absorption, and especially the targets of therapy in thyroid cancer. And this is an area that's changed quite a bit. So there are some newer targets that affect what replacement people should be on. But certainly another important topic we'll touch on is the thyroid hormone preparation. And that's really what I'll start with, because I know that's often a question that comes up. So there's a lot of guidelines out there. Here's a list of some, and we will use some of these as we talk about recommendations. The most recent from the American Thyroid Association is guidelines for treatment of hypothyroidism. And this does talk about the different preparations. which I'll also touch on, a kind of summary of what the recommendations are. But these are available if you just go online and Google either American Thyroid Association or European Thyroid Association guidelines. You can bring these up and read them. A hallmark or cornerstone of thyroid hormone therapy is something that everyone on the call has had, which is a TSH test measurement. So this is a blood test that we do. TSH is the hormone that comes from the pituitary and regulates the thyroid gland when that's working normally, but it also reflects the thyroid hormone replacement that you're on. And the reason why I show this graph is to highlight why we put so much emphasis on the test and why it's really one of the best tests we have to assess the therapy that you're on. So you can see on the x-axis that this is the free thyroid hormone level. So this would be a measurement T4, free thyroxine, you might see FT4. So this is a circulating level of T4, the prohormone that's in your blood. And TSH, shown here, then is the most sensitive assay. And I'll try to show you why here. These are patients graphing their T4 levels and their TSH, but you'll notice that this is a linear scale. So T4 is changing in a linear way, but TSH changes logarithmically. And Dr. Hershman, who's on the call, you'll hear from Third, was one of the originators of this sensitive assay of TSH that allowed us to be able to measure it and use it diagnostically, and especially sensitive at these lower levels. So here's the euthyroid, and this is people in the range of a normal free T4 and a normal TSH. But the point that I would make is that when the T4 levels drop, so here's a small reduction in the T4 level, that's amplified by a large change in the TSH. And that's why the TSH, we put so much emphasis on that, both to understand the adequacy of the replacement, but on the other side, so this is when the thyroid levels are low, often with thyroid cancer, because of the effect of TSH on stimulating thyroid cancer, we target a lower level than usual. And here's showing just a modest increase in the serum T4 concentration could have a very significant fall in the TSH. And Dr. Hershman will touch on these targets, but also there are some complications and side effects. And that's why as a patient taking thyroid hormone, you're going between wanting to feel good and having adequate levels of thyroid hormone. But when you have excess levels, that can be associated with some complications too. But if you both, when we talk about those targets and when Dr. LoPresti talks about thyroid hormone metabolism, this is the body's own way of monitoring the levels of thyroid hormone, and you'll hear more about that. This is just one study of many of patients with hypothyroidism on thyroxine replacement. First of all, this was about 2,000 patients. This was a study from South America, although many similar studies from around the world. Only about 60% of patients on thyroid hormone have the target range TSH. And so as I showed you over here with the euthyroid patients, this is in the target range for TSH, usually between 0.5 and 4 or so in most assays. So about 60% in the target, about 14% overtreated, meaning excess thyroid hormone, although as I mentioned in thyroid cancer, having a little bit higher T4 level is sometimes the target because having a suppressed TSH can prevent cancer recurrence. But about a quarter of the patients were undertreated. And what's interesting is of those that were undertreated, a significant portion of them complained of having symptoms. This was on a health-related quality of life scale, a standardized measurement of how people feel. And so generally those that are undertreated are in that category that just don't feel right on that thyroid hormone. And depending on the study, 15 or 20% or so of patients that are on thyroid hormone therapy have complaints, fatigue, low energy, things in this category. And that's really what's driven a lot of interest in some other preparations. And I'll give some introduction to that and touch on that. But I know at least from my last time speaking, this was a common question that was asked. So what do we use to treat thyroid hormone? Most of you likely are on levothyroxine. This is synthetic, and we refer to this as monotherapy, meaning that there's only one form of thyroid hormone that's part of your treatment. I'll give you a little bit of history on that because there have been changes over time, but because the body activates that prohormone, T4 to T3 in the body. Dr. LoPresti will talk more about that. Most patients do fine with the monotherapy. It's easier to monitor and to regulate. It has a long half-life, about 7 to 10 days. So it's relatively easy to administer and monitor. T3 is the active form of the hormone. It's not used as monotherapy, although some of you may have been on that as you prepare for withdrawal and have a whole body scan because it has less TSH suppression. But some do combine that with T4 to give a T4, T3 combination. There's a single tablet that combines synthetic T4 and T3, but what's emerging in popularity is desiccated thyroid. This is animal extract thyroid, which also has a T4, T3 combination. So just to understand the terminology, T4, most of you are on that. That's monotherapy, meaning just one form of thyroid hormone. And then the combined therapies are T4 with the active form of T3. And these vary either synthetic combination, giving T4 and adding the synthetic T3, or desiccated thyroid, which is a single preparation that contains both T4 and T3. And you may have been on that and feel better, more energy on the desiccated thyroid, but often there are some concerns, and I'll just show you some of the issues around that. Here's the typical formulations for T4. There's a lot of gradations, and this is because it allows us to fine tune the dose based on either these doses. Some of you may be above the highest dose of 200 because of targets to suppress the TSH, but by combining the various strengths, it's possible to very closely titrate the TSH to the target level. But historically, what's interesting is that although for the last 30 or 40 years, we've predominantly used monotherapy with levothyroxine, if you look way back, the initial studies were with various animal extracts. In fact, thyroid hormone deficiency was one of the first hormone deficiencies where it was recognized what the cause was. This myxedema coma from profound low thyroid levels was reversed by giving animal thyroid. And of interest too, that up until what I show here in 1965, about 80% of patients at this point were on animal extract thyroid. But at this point, there was a better understanding, or subsequent to this, of this conversion of T4 to T3 in the tissues that Dr. LoPresti will talk about. And we made a transition to that most patients were on levothyroxine monotherapy. But there is a lot of interest in who might benefit from adding T3 or being on combined therapy, and I'm sure we'll touch on that in the questions. But the one part I wanted to say, because you might say, well, why not just take the active form? That sounds good. Some patients feel better on that. And this just shows some varying doses and schedules, because T3 has a very short, relatively short half-life, 4 to 6 hours, compared to the long 7 to 10 days of T4. You can see in each of these graphs, the normal range is the 2 bars here. And then there's various schedules of both dose and frequency of giving T3. But you can see as you increase the dose that there's more oscillation. So this goes from 16.5 to 50 micrograms 3 times per day. And you can see very large excursions outside of the normal range. What looks pretty close, if you look at all those graphs, to kind of be within the normal range is this 10 micrograms twice a day. But it's very difficult with the T3, taking it just once a day to get a normal range and not have it go out of range. And that's the challenge, combining a long half-life medication like T4 with a short half-life one like T3. There is development of some sustained release T3, long-acting T3. It'll likely be expensive and not yet available, at least in the US, and that'll be something to look out for to combine that. And so far, with respect to, this is just a summary of guidelines, and part of our task was to touch on recommendations on thyroid extract and T4, T3 combined. These are the various thyroid organizations around the world. And mostly people have come out, certainly there is not data to recommend uniformly the patients benefit from having the T4, T3 combined versus T4 alone. And there's challenges that we'll touch on monitoring, as well as potentially side effects. But you can see several groups, the European Thyroid Association and the British Thyroid Association, both say that although routine use is not recommended, it may be reasonable to have a trial in patients who are not feeling right or feeling normally on the T4 alone treatment to combine T3. And I think there's ways to do that we'll talk about that are responsible and that respect the potential for complications as well as the target TSHs. And that I look forward, I think will be part of our discussion. So that's background to talk about the different formulations, the testing, and just start to talk about some of the issues of the different formulations. And I'll turn it over to Dr. LoPresti to talk about thyroid hormone metabolism.
Okay, thank you, Greg. Yeah, so my plan today is to discuss understanding thyroid hormone metabolism in humans. And it's going to be a summary of the data that my mentor, Dr. Nikoloff, and I did over the last 15 years or so. And I'm going to discuss the three major hormones, T4, T3, and reverse T3, and the potential role that they play in thyroid metabolism. So here we have the thyroid gland. Go ahead, Greg. And it secretes two hormones. The primary is T4, and it also secretes a small amount of T3. And that accounts for about 20% of circulating T3. Next slide, Greg, please. Okay. The majority of T4 is then shunted to what I call an activating pathway, where T4 is converted to T3, the active hormone, by a 5' deiodination. And this occurs in peripheral tissues, and this appears to occur outside the liver. And this accounts for about 80% of circulating T3 levels. On the other hand, there's also another pathway, Greg, that is an inactivating pathway, and that is regulated by another deiodinase called the 3,5 deiodinase, and that forms the inactive product reverse T3. So I'm going to talk about how these various hormones interact and how we can use them in diagnosis and treating thyroid conditions. Next slide, Greg. So what I'm going to talk about here briefly is the role that T3, RT3, and T4 play. Next slide. On the top here, you have T4, and the 4 refers to the number of iodine molecules. There are 4. And there, you can see they're designated as a 3', 5', 3, and 5. And these are, through various removal of these iodines, you can form either the active or inactive hormone. Go ahead, Greg. And so if you remove the 5' iodine through this enzyme called the type 2 5' deiodinase, you form the active form of thyroid hormone T3. Next slide. On the other hand, if you remove the 5 iodine here on the inner ring, that leads to the inactive product called reverse T3. And what I'll do in the next few slides is show you how these interact. And I just have to preface this is only going to be relevant in the healthy and fed state. Next slide, Greg. Go ahead and hit the.
Okay, sorry.
Yeah. Okay, so this is sort of the pattern of T4 disposal you'll see in a healthy and fed individual. About 47% of T4 disposal goes to converting to the active form T3. About 27% goes to the inactive product, reverse T3. And then the remainder goes to this other pathway called other, which I'm not really going to discuss today. So now we're going to talk about how each of these various thyroid hormone metabolites can be used. Next slide. So the inactive hormone, can circulating T3, RT3 levels be used to determine thyroid status? In other words, can you, by using an RT3 measurement, determine whether or not a patient is hypothyroid? Or can you use RT3 to monitor response to therapy in thyroid dysfunction? Next slide. So the first question is T4 shunted as an activating pathway? So on the y-axis, we have RT3 T4 ratio, which is used as an estimate of conversion of T4 to RT3. On the x-axis, you have free T4 levels. And what you can see here is that the RT3-T4 ratio does not change with changing T4 levels. Next. So what this means is the RT3-T4 ratio is constant at all T4 levels. So there really is no shunting in the healthy fed individual to inactivating pathways. Go ahead, Greg, next slide. So can we conclude that conversion of T4 to RT3 is fixed, and in the healthy state, RT3 levels do nothing more than reflect serum T4 levels. And so there's really no role for RT3 measurements in either monitoring patients with thyroid dysfunction or making the diagnosis of hypothyroidism. Next slide, Greg. So let's talk about the regulation of the active hormone, the regulation of circulating T3 levels in humans. Next slide. So again, this is looking at the influence of circulating T4 levels on conversion of T4 to T3. So it's a very similar arrangement. So on the y-axis, we have T3-T4 ratio. It's used as an estimate of conversion of T4 to T3. And you have the T4 value on the x-axis. And as you can see at low T4 levels, there's a very high T3-T4 ratio. And as T4 levels increase, this ratio drops. Next slide. And so conversion, what led us to believe conversion of T4 to T3 is increased at low T4 levels and decreases with rising T4 values. These were just done on circulating hormone levels. So we went on then to actually estimate the conversion in various T4 states. Next slide, Greg. So here we have the percent conversion of T4 to T3 in altered T4 states. So in the normal individual with normal T4 levels, as I showed earlier, about 47% of T4 is converted to T3. As T3 levels rise, there's actually a drop in conversion of T4 to T3 down to about 41%. And in patients with chronically low T4 levels, the conversion is upregulated to about 53%. Next slide. So conversion of T4 to T3 increases with falling T4 levels and decreases with rising T4 values. Final slide, Greg. So what are the conclusions? So peripheral thyroid hormone metabolism is designed to maintain circulating T3 levels in the normal range. Next. In high T4 states, such as with T4 suppression, like as we will use in patients being treated for thyroid cancer, conversion of T4 to T3 is reduced to mitigate the effects of excess thyroid hormone on any patient taking levothyroxine. Final. In low T4 states, such as with hypothyroidism, conversion of T4 to T3 is enhanced in an attempt to maintain a euthyroid state. And so, thyroid hormone metabolism plays a very important role in trying to maintain a patient in a euthyroid state, regardless of the T4 levels. So that's it, Greg. Thank you.
Thank you. So we'll finish with Dr. Hershman.
I'm going to start with this busy slide because when thyroxine T4 is taken, there are conditions that interfere with its absorption into the body, and this busy slide lists a large number of drugs on the left and to some extent on the right that interfere with thyroxine absorption. A big drug that interferes is iron, ferrous sulfate. Now, whether the amount of ferrous sulfate in multivitamins or the small amount of calcium can interfere is really unknown, but it can be of concern. But iron binds the thyroxine very strongly, so you can't take the two together because you won't absorb the thyroxine. Calcium salts will interfere. And as little as 500 milligrams of calcium in any one of these common preparations will interfere with thyroxine absorption. Not absolutely wipe it out, but it'll interfere. And then there are some medical conditions such as celiac disease or surgery, often done for obesity, will interfere. And it turns out that if acid secretion is markedly reduced, which can be caused by some drugs, then like proton pump inhibitors that interfere with acid secretion, that will reduce thyroxine absorption. Now, the data on whether the histamine 2 receptor antagonists that reduce acid secretion, not as strongly as the proton pump inhibitors, on whether those will interfere is kind of controversial. They're not used much nowadays, so it may not be so important. Another big interference is taking the thyroxine with a meal or some things that you eat, like the espresso coffee can interfere, strong coffee, whether weak coffee will interfere is not so clear. And then high fiber diet and soybeans can interfere with thyroxine absorption. And there are probably some other things that are not even listed on here that interfere. And unique patients, for example, patients on dialysis who are using phosphate binders will have interference, but fortunately that's a small proportion of the population. Next slide. Now, in order to avoid interference with thyroxine absorption and make it as strong as possible, there are some recommendations about when to take it. So it is recommended that the levothyroxine should be consistently taken either 60 minutes before breakfast with the empty stomach or at bedtime 3 or more hours after the evening meal. There's also a recommendation next that it should be separated from interfering compounds that I described previously. Now, how long to separate it is not clear. A 4-hour separation is traditional, but there aren't a lot of tests to show that. So in general, try to take your thyroxine separate from these medicines that are known to interfere. People take a lot of medicines that are for other purposes, and I think that most of them will not interfere, like taking statins, for example. That's probably not going to interfere with thyroxine absorption. There's no data about that. Next slide. So I'm now going to turn to the TSH targets that we aim for in patients. And the patients can be divided into those who have a high risk of recurrence of thyroid cancer. And in that case, to prevent any growth promoting effect of thyroid stimulating hormone, it's best to keep the TSH level as low as is reasonable, such as below 0.1 milliunits per liter. For patients who have an intermediate risk of recurrence and haven't had a recurrence for a significant period of time, just keeping the TSH somewhat subnormal, maybe into the very lower limit of normality is all right, but that's just a weak recommendation because there's not so much evidence about it. And then for patients who are very low risk, who are not likely to have a recurrence, it's all right to keep the TSH either at the lower limit of normal or into the normal range. Next slide. Now, why are we concerned about that? Well, an excess amount of thyroid hormone that is ingested causing a low TSH as an indicator can have effects on the bone to reduce bone mineral and even cause osteoporosis. The heart is another target of the thyroid hormone, and if too much thyroxine is given, you can not only have tachycardia, but you can develop atrial fibrillation. And if it's sustained over a long period of time, even without atrial fibrillation, there can be an increase in the thickness of the heart, which is not desirable. So those are the main reasons, aside from causing some nervousness and anxiety, for avoiding an excess amount of thyroid hormone. Next slide. So you have to strike a balance between the risks of TSH suppression going from none when the TSH is the normal range to atrial fibrillation when it's pretty bad, versus the risk of recurrence, whether it's a very low risk, excellent, no risk, to a structurally incomplete resection or evidence on some structural examinations that there's some recurrent tissue, aiming for just in such patients suppression. So we have to vary the suppression from none to mild to a moderate degree of suppression. And I've got 2 more slides that'll elaborate on this. Next slide. So there have been some mild differences of opinion about the thyroid cancer targets based on the risk of recurrence, as shown in what's shown below. So if the risk is high, the open arrows, then the American Thyroid Association and the European agree keep the TSH less than 0.1. And if the risk is very low, at the time this slide was created, the American Thyroid Association was somewhat more liberal in allowing the TSH to go into the normal range compared with the European Thyroid Association. The next slide is a more specific summary about this. And this is our last slide. Suggested TSH targets in thyroid cancer patients according to the risk assessment during follow-up. So if the risk of therapy is high, as in an older patient who may have cardiac disease, we do recommend, nevertheless, that the patient have a thyroxine dose that will keep the TSH in the very low range for a period of time. And then as there's no recurrence, but still it's a high-risk patient, the TSH might still be maintained somewhat on the low side if the patient's disease-free for 5 to 10 years. In those with an intermediate risk of recurrence, but they're a high risk from therapy, they're an older patient, touch of cardiac disease, we might liberalize the TSH, still try for a number of years to keep it on the low side before raising it into the normal range. But if there's a very low risk of recurrence, clearly maintaining the TSH in the low normal range is all right. All right, so let's go to the patient who's a very low risk, the third line. Oh, gotta go stay on that slide. Can we go back to the slide? Well, let me say that. All right, well, if there's a low risk of recurrence, then the TSH can be maintained in the normal range, even perhaps to start with. But if there's a high risk of recurrence and the patient who can tolerate it, of course, we maintain the TSH very low. And in the patient who's an intermediate risk, we like to keep the TSH low for a period of time, and then as there's no recurrence, to raise it a bit. And if there's the intermediate risk of recurrence, we do something in between, maintaining the TSH low to begin with, and then as there's been no recurrence, liberalizing it. And if there's a very low risk of recurrence and an intermediate risk from therapy, we would just maintain the TSH in the normal range. And I hope that this is all clear to you, because I'm sure many of you are concerned about these issues. And now I think we can go on to questions.
Jerry, can you see the questions, the Q&A?
Yeah, would you like me to read those to you, or would you like to go through them yourself?
I think we can go through them.
Okay.
I can't see them, so
Okay,
I'm sorry.
I could do it if. Okay, so I'll just go. And actually, the first one is a good one, which I meant to. So the first one: do we prescribe liquid thyroid hormone or Tirasol, Tiracent for your thyroid cancer patients with GI issues, malabsorption, celiac disease? When do you typically prescribe it, or if you don't, why? So do you want to, Jerry, what's your on Tirosint or the
I
liquid
think,
preparations?
yes, there's a lot of data. I can't see myself on here, but I'm sure that I suppose you can see me. I did something on my screen.
We
Anyway,
can see you.
Tirosint is a liquid preparation that is pure levothyroxine. And there are many studies, they're mainly European, mainly Italian, that show that patients who have gastrointestinal conditions which interfere with absorption of the tablet levothyroxine do not interfere with this liquid preparation that's given in the form of a gel capsule. And that is also true if you reduce acid secretion with the proton pump inhibitor. And some patients who have to take very large amounts of levothyroxine, even for unknown reasons, do better on the Tirosint. So I think it's still evolving. Of course, there's a cost issue in regard to using the Tirosint.
John, do you have what's your feelings?
The other time that I use it quite often is in people who require tube feeds, and they have to, have their medicine delivered by tubes. And it's very hard to get, to grind up the tablet. And so the time I use it, almost exclusively is someone that's dependent on tube feeds and they require thyroid hormone, and I will use it there because it's a much easier way to deliver and better absorbed in that particular situation. But outside of that, I agree with what Jerry said.
All right. Yeah, and I think that there's good data. The main downside from my point of view is just the cost, but otherwise,
Right.
yeah, it's fine to use, same preparation, and is better absorbed. So someone on Loxo, selpercatinib for over 2 years, this is probably Jerry I'll start with, during which I visited the clinical trial testing the thyroid. I'd like to know how to get the best thyroid measurement for optimum energy. So these agents do interfere with thyroid function, although if you're thyroid cancer and have had your thyroid out, it probably is not an additional change. But Jerry, any comments on that?
I'm sorry, I missed the question. What is the drug or procedure?
So it's a
that you're
tyrosine
discussing?
kinase inhibitor, I think, that which can, if you have a thyroid, that can interfere with thyroid function, but if it's gone, shouldn't especially affect the measurement.
Actually, Greg,
Oh yeah,
some
please.
evidence tyrosine kinase inhibitors
I
alter
think
thyroid hormone in the liver, and
Okay.
you shunt it into the body. So you may require more thyroid hormone on the tyrosine kinase inhibitor.
It's good. That's why we have a whole panel, so you can get the
Yes,
real
that's very
expertise.
common.
Good. Thank
Many
you.
of them.
So any differences, John, in monitoring if you're having this effect? Should you measure T3 in addition to T4 or?
I usually just use T4 and TSH. It's a similar situation that you're going to see with the anti-TB meds and heart therapy. They also do the same. They have the same effect on the liver. And so typically in the patients I've seen, their thyroid hormone requirements go up to maintain the levels of TSH that Jerry talked about.
Okay, so there's a lot of questions, so I'll try to give them just one of you. You're both experts in this, but this is a great question. What tests should my doctor be doing? Typically, they only do T4 and TSH. I'm only on Synthroid, and my biopsy, along with thyroid cancer, has discovered Hashimoto's. Not sure if that plays into regulation. I struggle with bouncing between hypo up to TSH is over 5 to below therapeutic dose, making me very hyper. I also struggle with hypocalcemia, not sure how this plays into dosing with thyroid hormone. Dr. Hershman did the original studies on calcium and thyroid hormone too, so I'll ask him if you can address that. What testing should Diana have, and what about bouncing around?
I think, well, as I mentioned, the calcium, if you take, because of hypocalcemia, if you are taking calcium preparation along with thyroxine, try to separate the calcium preparation from the thyroxine. The calcium preparations are best absorbed after a meal. So ideally you would take the calcium after supper and take the thyroxine early in the morning. Hashimoto's by itself does not interfere with thyroxine absorption, but patients with Hashimoto's are predisposed, perhaps 10% of them can have celiac disease and have interference with thyroxine absorption. So you might be checked on that for that to see if you require a gluten-free diet. The test to determine if you have celiac disease along with the Hashimoto's are now very good. And so I think your doctor could do a test for the celiac disease to see if that's a factor in your malabsorption and thyroxine causing you to take different doses.
Right. And so when someone's bouncing around like that, you want to go through if there's some issue with absorption, you could try the tyrosine. And you don't routinely, Jerry, do a T3. We know not to do a reverse T3. We've heard that. Do you add, is a T3 helpful to measure?
Well, I think for patients who don't feel ideally well, measuring T3 to see if it's really very subnormal, which can occur in a small number of patients perhaps, can provide some useful information. But in general, I follow the patients with a TSH and a free T4 measurement for their replacement therapy when they have thyroid cancer.
Okay, John, I'll give you this one. I take levothyroxine, but have been asked to take birth control to manage severe endometriosis. So we know that can have an effect. I've tried several times to take the birth control, but it significantly throws off my levels. Are there any suggestions, medicines that are better than others in a situation like that? And I'll add, how does the birth control affect thyroid hormone measurements?
Well, birth control will increase thyroxine binding globulin. And that, when you have a high TBG level, it actually interferes with the normal free T4 measurements, and they become somewhat inaccurate. And that would probably why you're having significant changes in your levels, just because of the assays don't respond well to that high protein level. So, you know, the only suggestion would be is if you could take a lower estrogen birth control and have a less effect, or non-estrogen containing birth control, to minimize the effect on TBG, which should help you get a more accurate serum thyroid hormone measurements.
So, John, just to additionally,
data.
Yeah, Jerry, go ahead.
I think there are some good data that show that when patients take estrogen, which is of course usually in the usual birth control, in pharmacologic amounts, that will increase thyroxine requirements to maintain the TSH in the normal level. And when they go off the birth control or estrogen preparation, then the TSH can become subnormal. But if you're on the same amount of estrogen every day, that should not interfere. That as you develop a thyroxine dose, it brings the TSH to the target, and then just stay on that, and it should not vary.
All right, and Jerry, you addressed this. I'll ask John to address it. It's a similar question. Jerry said there may be some patients that have relatively low T3. How do you know if you're having issues converting T4 to T3? What would that look like on labs? How should it be tested and treated?
That's $1 million question, right, Greg?
Okay,
You know,
yeah.
all this stuff, we did it with radioisotopes, which obviously you cannot do to estimate that. That's a very difficult question. So what I can tell you, and I did remove this slide, when we looked at various patients with hypothyroid, there was a subset that actually had less conversion than even a euthyroid patient. But I couldn't pick that up by physical exam or by study hormone testing. So that's a very difficult question to answer, and I don't know of a good way to assess that.
So not reverse T3 doesn't help, but to identify the subset is tough. Okay, Jerry, do you have patients? Yeah, go ahead.
I was going to say, because reverse T3 is fixed. Okay, I know some people talk about maybe there's a higher reverse T3 that may play a role. That, and I didn't include that, but the only time you get a high reverse T3 is when you're sick. And it doesn't affect conversion, it affects clearance. So the levels go up, but the same amount of T4 is going to RT3. The only reason you see a high RT3 is it's no longer being broken down.
All right, thanks. So Jerry, I'll give this one. Do you ask what instructions do you give your patients on testing day with respect to taking their dose of thyroxine? So the individual's been told to hold it prior to the test. What do you tell your patients?
Well, that's a tough one. And in truth, I don't advise my patients in that regard because of the very long half-life. I think that it doesn't fluctuate much after ingestion. There are, on the other hand, some studies that show small fluctuations that might make a difference. I don't think it affects TSH. I think it might affect the free T4 more. But if you're on the same dose, I don't think it affects the TSH. So I don't think that it matters. It could matter if you're taking preparations which contain T3. But again, if we're using TSH as the most sensitive target for making adjustments, I really don't think whether you take the preparation in the morning before you get tested or skip it until you get tested makes a difference.
John, what do you tell your patients?
Just take your medicine, come in and get your bloods drawn.
Okay.
No problem.
So difference between total T4 and free T4, I'll take that most people, so free T4 is the non-protein bound. We do an indirect measurement or estimate, but total T4 is the whole amount of T4, include the bound and the free. It's directly measured, but usually it's combined with an estimate of the free fraction. But by and large, almost every center, people are having an indirect measurement of free T4. So it's just a matter of which is being measured. You just have to know and have the appropriate reference or normal range. And it's mainly significant if people have conditions that affect their binding protein. So pregnancy is one, so that would be where it's important to know what's being measured. And things like estrogen we talked about can increase binding protein. So John, here's one. How does exogenous T3, we've talked about that, affect conversion of T4 to T3?
Okay, exogenous T3 does not actually affect the conversion process of T4 to T3. What exogenous T3 will do, and probably not in the physiologic range, but what we showed is when you give T3, you actually increase T3 disposal. And so the net result is, again, body's attempt to keep T3 in that, what is considered the normal range. So if you give too much T3, you'll actually shunt T3 away from the circulation and primarily out into the bile.
Okay, thanks. So this is a question, I'll give it to Jerry. I'm an MTC survivor, recently diagnosed with Hashimoto's. So again, I think anyone that with significant thyroid cancer has had their whole thyroid removed, but chose to have the T3 and T4 combination as a common when having MTC and Hashimoto's. So does that affect your response to preparation?
Well, the medullary thyroid cancer comes from the C cells, but because it is a condition that's more worrisome than many of the differentiated thyroid cancers, patients are given have a total thyroidectomy. So they must take thyroid hormone. Now, they do not have to take a suppressive doses of thyroid hormone. And I think as far as taking levothyroxine versus desiccated thyroid or T4, T3 together combination that's adjusted for the patient, I don't think it matters as long as the TSH is in the normal range. Generally, patients are treated with levothyroxine alone, but in contrast with what I said about suppressing TSH, there is no role for suppressing TSH in patients with medullary thyroid cancer. And I think the same is true if a patient has underlying Hashimoto's thyroiditis.
Okay, thanks. Now there's several questions here that are especially important for this group that I want to be sure we address. And that's Jerry and John, I want to hear both of your responses on this. I'll combine a few. So you talked about, Jerry, risk of recurrence, that dictates how the TSH target. So how do you know what the risk of occurrence is or determine it? for high-risk patients, how long to keep the TSH under 0.1 lifetime. And then the third one, which we're all combining those, how do you determine if a patient with papillary cancer and total thyroidectomy is high or low risk? So maybe start with Jerry, just how's the high and low risk determined, and how long might you have to keep below 0.1 if you're high risk?
It's a very good and complex question, which could take a long time to answer. So I'm going to deal
But we
with
don't have that time. So you can...
what you asked. I know. Thank you. What makes a patient high risk is whether there's been a complete resection of the thyroid cancer, whether it's possible to resect it all, whether the pathology shows that it's a tumor with high risk because of the characteristics of the tumor, whether it's spread beyond the thyroid, and whether there's metastatic disease. So all of those factors are taken into play in regard to high risk. Then as patients are followed with imaging studies and thyroglobulin, we see how they're doing. Patient can appear to be high risk, but as they're followed, it seems like thyroglobulin is undetectable and the imaging shows no recurrence, and then the patient moves perhaps out of the high risk. But when a patient is considered high risk, we keep the TSH very low until there's good evidence by following the patient that this risk is reduced. I better stop here.
That's the very, John, do you?
We rely a lot on thyroglobulin at USC, and we look at doubling time in thyroglobulin. I think that sort of encompasses every aspect, it encompasses the completeness of surgery and thyroid hormone suppression. So we determine it by the post-op thyroglobulin. If the thyroglobulin comes down and the values we used at USC is less than 0.5 and it's stable, that's considered a low-risk patient, regardless of what the pathology says. On the other hand, if the thyroglobulin remains elevated, again, regardless of what the pathology says, that's the high-risk patient. And those are the ones who will leave on thyroid hormone. And if it's in the risk group that Jerry mentioned, for AFib and osteopenia, osteoporosis, we'll add a beta blocker. This beta blocker will mitigate the effects of thyroid hormone on the heart and actually reduces the increased bone turnover from thyroid hormone excess. So the discussions we have in our clinic is, okay, which is the greatest risk, the thyroid cancer or the thyroid hormone suppression? If it's the thyroid hormone, if it's the suppression and the cancer is okay, we'll lower the thyroid hormone dose to the ranges Jerry recommended. And if it's a high-risk patient, we'll add a beta blocker because they need the thyroid hormone suppression. So we rely more on thyroglobulin.
All right, and then so somebody asked in terms of the espresso, so we alarmed some people. If you wait 60 minutes, does it no longer interfere with absorption, Jerry? How long does it last?
I'm sorry. What is the drug that might interfere?
So espresso coffee. When you drink espresso coffee, if you separate it out, can you still have your thyroxine and have your espresso separated by 60 minutes?
I think if you take the thyroid hormone before 1 hour before the espresso, it's probably all right. The studies showing espresso interferes were, I believe, with concomitant ingestion, a very old Italian study. So I think
just a reminder that we have about 5 minutes left.
All right, so thank you. And I did want to, there's a long question, but I know that from my previous times that there's a number of you that have this concern, so I do want to especially address it. I alluded to in my area, but there's an individual who only feels better when they're on thyroid extract, Armour thyroid, but their TSH is bouncing around in part because they have trouble getting insurance coverage for through Medicare for the Armour thyroid, has to fight with them. So just is exhausted by having to go back and forth to get this coverage. So Jerry, do you know anything about the, for your patients on Armour thyroid, has that been, I know you have some, is that a struggle to get coverage for that?
I'm not aware of it. I thought that the Armour thyroid was quite inexpensive. So I'm not aware that Medicare it makes it difficult. I think if you take the Armour thyroid and have a TSH that's in the target range, that's good. The dose, of course, if the target is less than 0.1, the person might be intoxicated, and then I think that's a good basis for measuring the really the T3 level as well as the T4. You don't want it to be too high, and you don't want to have side effects from taking it. But as long as the TSH is in a target, for example, when we aim for just a mild suppression with a TSH that's measurable easily, it's all right, I think, to take it as long as the patient doesn't have side effects. It's not the preferred preparation. Thyroxine is the preferred preparation, but some people insist that they don't feel well on it, and they do feel well on the Armour thyroid at a dose that's reasonable.
John, do you have any, I don't think you have patients on Armour thyroid.
No, just the one who refuses to come off.
Okay. I'll just answer in our last minute here. Any risk to T3 long-term, as long as with the study, I didn't have time to show it, but as long as the TSH is at target, then that's really the risk. Most people on T3 or many take excessive levels and suppress the TSH, and then that's at risk. With respect to the proton pump inhibitors, this is important that you don't minimize the effect, or it's by separating it, because the activity of the proton and pump inhibitors is to raise the stomach pH, and that condition is what reduces absorption. Someone also asking about antidepressants, so especially the serotonin reuptake inhibitors can also increase the dose, but both of those are generally chronic. So if you're set on your proton pump inhibitors, your antidepressant, then you want to just titrate your thyroxine in that environment. It's not an impairment of absorption in the same way.
Greg,
and
there's a question, why not use circulating T3 to assess thyroid status? That should be mentioned briefly.
Sure, please.
Any illness or a lot of medications will inhibit conversion of T4 to T3. So T3 is too variable. Too many things can affect conversion or T3 levels. So it makes it a less reliable marker of thyroid status.
All right, I think we're at the end of the time, but thanks so much. Sorry we couldn't get to all the questions, but really appreciate the interaction. Thank you, Roberta.
Thank you, everybody. Enjoy the rest of the day.